The patient's progressive dyspnea, orthopnea, bivascular lung crackle, and lower extremity edema are classic for decompensated heart failure. Echocardiography shows a left ventricular ejection fraction, normal left ventricular ejection fraction, which is more than 50% consistent with heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction results from diastolic dysfunction, impaired relaxation with decreased compliance that leads to elevated left ventricular pressure and reduced cardiac output. Concentric hypertrophy due to chronic hypertension and usually a primary contributor, causing normal sized left ventricular cavity with thickened walls. Obesity and sedentary lifestyle are often strong contributors, in part through their association with hypertension, but also via systemic inflammation that leads to microvascular myocardial ischemia and deposition of interstitial collagen. Atrial fibrillation, which is likely present in this patient with palpitation and irregular pulse, is a common precipitant of acute exacerbation of heart failure with preserved ejection fraction. Due to an impaired diastolic filling at baseline, patients with heart failure with preserved ejection fraction are highly sensitive to loss of the atrial kick that occurs with atrial fibrillation. It is not cor pulmonale, which refers to right ventricular failure due to pulmonary pathology that leads to pulmonary hypertension like COPD, pulmonary embolism. Pulmonary edema is not present with isolated right ventricular failure. These patients' bivascular crackle and orthopnea suggest left ventricular failure. So this question is diagnosed what are the points, like why it is not high output failure. Uh, what are the key points you find out in this question? Why you choose diastolic dysfunction? Bibasilar crackles, yes. Yes. Small area bronchoconstriction looks like asthma. Yes. No. High output heart failure involves increased cardiac output in response to a condition causing reduced systemic vascular resistance, like AV fistula or hyperthyroidism. So, hyperthyroidism, AV fistula can cause high output cardiac failure. Echography shows dilatation of the both right and the left ventricle as they accommodate the high flow state. So in here, just the main clue is hypertension and associated atrial fibrillation. There is heart failure signs, left heart failure signs, along with the right heart failure signs also, like pitting edema. And left ventricular ejection fraction is more than 50 because it is heart failure with preserved ejection fraction, not reduced ejection fraction. Okay. And chronic hypertension is concentric hypertrophy, cause of the concentric hypertrophy. Okay. Okay. Syncope has a broad differential diagnosis from begin to life-threatening conditions. Exertional syncope usually portends exertional syncope usually portends an underlying pathologic cause, including ventricular arrhythmia due to myocardial ischemia or infarction, and outflow tract obstruction, aortic stenosis, hypertrophic cardiomyopathy. Initial presentation of progressive syncope. Initial presentation of progressive syncope during exertion, fatigue. Exertional syncope is suggestive of output outflow obstruction. Patient with fixed outflow obstruction, severe AS, cannot increase cardiac output in response to exercise-induced vasodilatation, leading to hypotension, transient cerebral hypoperfusion, and decreased exercise tolerance pre-syncope. Physical examination findings suggestive of severe AS include delayed and diminished carotid pulse, pulsus parvus and tardus, presence of single and soft heart sound S2, mild to late peaking systolic murmur with maximal intensity at the second right intercostal space radiating to the carotids. Okay, yes. So blood pressure differential between the upper and the lower extremity is seen in aortic coarctation, which can present with hypertension, headache, blurred vision, epistaxis, lower extremity claudication. A continuous murmur is heard at the left interscapular areas due to turbulent flow across the coarctation or through large collateral vessels. And an opening snap and a late diastolic murmur is heard at the apex. An opening snap and a late diastolic murmur heard at the apex are characteristics of mitral stenosis, which can present with decreased exercise volume, exertional dyspnea, and less commonly chest pain, hemoptysis, or lower extremity edema. Exertional syncope is not seen. Prominent capillary pulsation in the fingertip or nail bed can be seen with air as a result of widened pulse pressure. AR can present with progressive dyspnea and fatigue, but is unlikely to cause exertional syncope. Pulsus paradoxus refers to exaggerated decrease more than 10 mm of mercury in a systolic blood pressure with inspiration. It is commonly seen in pericardial disease, cardiac tamponade, and can occur in other causes like asthma, COPD, and orthostatic hypotension. Refers to a drop in the systolic blood pressure, more than 20 mm of mercury, or diastolic more than 10 in 2 to 5 minutes of standing from a supine position. It does not cause exertional syncope. So aortic stenosis with decreased exercise tolerance, exertional syncope, angina, physical examination, delayed and diminished carotid pulse, soft heart sound, mild, mid to late peaking systolic murmur at maximal intensity at the second right intercostal space radiating to the carotid. Okay. Is it USA? Sorry. BMI is high. He is snoring a lot. Okay. Is it angina type of thing? Oh, so I got right after hearing you. Nah, snoring and BMI is also high. BMI is 34 is higher. Okay. This patient's dyspnea and burning sensation. This patient's dyspnea and burning sensation with exertion in the setting of multiple risk factor for coronary artery disease, obesity, smoking history, likely likely undiagnosed hypertension raise suspicion for stable angina or myocardial ischemia that reproducibly occurs with an increase in myocardial oxygen demand. The fact that the same burning sensation occurs with minimal exertion after eating heavy meals now at rest. The same exertion after hitting heavy meals now at rest raises concern for unstable angina or angina resulting from obstruction of the myocardial oxygen supply, that is atherosclerotic plaque rupture, critical atherosclerotic stenosis. Unstable angina is the least common type of Unstable angina is the least common type of acute coronary syndrome. The diagnosis is based on the history alone, and history alone. The diagnosis is based history alone of the rest angina or rapidly worsening stable angina symptoms. By definition, troponin levels are not elevated and ECG is unremarkable or reveals only non-specific finding T-wave abnormalities. Although the myocardial ischemia is not sustained enough to cause detectable serum troponin elevation, unstable angina signifies a poor short-term prognosis and prompt intervention is warranted. The management of unstable angina is the same as that of the non-ST elevation of myocardial infarction. Okay, yes, yes. Cor Cor pulmonale is the right ventricular failure that results from cor pulmonale is the right ventricular failure that results from a disease process in the lungs that leads to pulmonary hypertension, usually presenting with pitting lower extremity edema, hepatomegaly, and jugular venous distension. Hypoxic pulmonary vasoconstriction due to severe chronic obstructive pulmonary disease or obstructive sleep apnea are common causes. This patient's smoking history puts him at risk for COPD, and his snoring and elevated BMI raise suspicion of OSA, but he does not have significant signs of right ventricular failure. He does not have right ventricular failure. And esophageal spasm presents with dysphagia to solid and the liquid that is often associated with retrosternal chest pain and or reflux symptoms, heartburn, regurgitation. Hiatal hernia is usually asymptomatic, but it may cause reflux symptoms when large. These diagnoses these diagnoses would not explain the patient's dyspnea or chest discomfort elicited by mild exertion or now occurring at rest. Okay. Peripartum cardiomyopathy, PPCM, peripartum cardiomyopathy is an uncommon cause of dilated cardiomyopathy that develops during the last month of the pregnancy or within 5 months following delivery. The patient's clinical presentation with progressive dyspnea, exertion, lower extremity edema, and S3 suggestive of decompensated heart failure due to peripartum cardiomyopathy. Peripartum cardiomyopathy often causes secondary MR, which can be recognized by a hollow systolic murmur. The diagnosis of the PPCM peripartum cardiomyopathy can be difficult in the late pregnancy because many symptoms and signs dyspnea dyspnea, edema are similar to dyspnea edema are similar to changes in normal pregnancy. This patient S3, uh, this patient S3, 3 or 4 murmur, significant edema, and limited dyspnea, needing to stop after walking a few steps raise concern for PPCM. A transthoracic echocardiogram showing a dilated left ventricular cavity with global systolic dysfunction and ejection fraction less than 45% can confirm the diagnosis. Management is similar that of other types of systolic failure, beta blocker, diuretics. Urgent immediate delivery should be considered only for patients with advanced heart failure or hemodynamic instability. Okay, mid systolic murmur. In S4 there are like three causes. Acute MI can come with S4, and other like AR or MR. Yes, AR cannot cause this murmur. Maybe. So there, what will be the benefit? Vague. He's a young boy. Oh, he's a young boy. Is it? Sorry, young. Sorry, young woman. And related to sports, is it HOCM? And HOCM has this type of atypical site, atypical murmur. Yes, it's HOCM. I am just trying to find out the sports. Like HOCM has related to sports, like his player, he's died in the football field, like that. And this murmur, like HOCM murmur, you cannot correlate with the other murmurs. You cannot correlate with the, yes. Okay. So we will read the box first, like management of the HOCM. If the HOCM is asymptomatic, routine clinical monitoring should be done. If the patient is symptomatic, mm, like this patient with dyspnea and angina, beta blocker or non-dihydropyridine calcium channel blocker, that means verapamil diltiazem. If the high risk for sudden cardiac death, prior syncope, sustained VT, family history, implantable cardiac defibrillator placement should be done. If patient comes with atrial fibrillation, and rhythm control, rate and rhythm control and anticoagulation. If refractory symptoms, significant left ventricular outflow tract obstruction and non-obstruct significant left ventricular outflow tract obstruction, septal ablation or surgical myectomy, and non-obstructive is cardiac transplantation. Got it? Okay. Now the explanation. This young patient who experienced exertional syncope and has an S4 mid-systolic murmur at the left sternal border, most likely HOCM. HCM most commonly results from autosomal dominant gene mutation. Depending on the degree of the hypertrophy and the left ventricular outflow tract obstruction, patients with HCM have no symptoms and may have no symptoms or may have a significant dyspnea, chest pain, palpitation, pre-syncope, syncope. Symptomatic patients with HCM should be treated with beta blocker, metoprolol, which improves symptoms by increasing left ventricular volume to decrease the left ventricular outflow tract obstruction in in two ways, like negative chronotropy and negative ionotropy. Negative chronotropy slows heart rate to increase left ventricular volume time and increase left ventricular end diastolic volume. And negative ionotropy is decreases myocardial contractility to increase left ventricular end diastolic volume. Baseline left ventricular volume is increased. Okay. This may be the new information, like novel agent mevacametin mevacamtin that reduce the contractility via modulation of the cardiac myosin are under in you got it, like Nobel agent. Non-dihydropyridine, the last line of the non-dihydropyridine. Yes, yes. Okay. You just don't say this type of word. Just don't utter this type of word. Then you will find this word in the exam hall. I have seen it multiple times. Whatever I just try to, no, it cannot come. I have seen in the exam hall. No, no, no. In my other exam, I have told. Next, left tunnel border. Just listen. They have said left tunnel border. So left tunnel border has three murmur. What are those? Like AR, PR, and VSD. Yes, upper and lower. Yes. So it may be either bounding pulse like AR, or it may be fixed splitting like ASD. Now you need the murmur to auscultate. It may be. Okay. Okay. So we did not need to read the explanation in here. Okay. Because you know everything, like bounding pulse is AR, fixed splitting is ASD, pulsus paradoxus, you know the pulsus paradoxus, like if BP falls more than 10 millimeter of mercury during inspiration, that is pulsus paradoxus. And pulsus parvus and tardus is comes with the aortic stenosis, like crescendo, decrescendo, systolic murmur. Got it? Next. Okay, this patient has severe mid-sternal chest pain. This patient has severe mid-sternal chest pain and ST segment elevation on ECG. ST segment elevation on ECG consistent with acute coronary syndrome. Given recent coronary angiography and drug-eluting stent placement, stent thrombosis should be highly suspected. Both bare metal and drug-eluting stents are thrombogenic, and following placement, there is a period of increased thrombotic risk. There is a period of increased thrombotic risk 6 to 12 months until stent endothelialization occurs. This increased thrombotic risk is mitigated by administration of the dual antiplatelet therapy with aspirin and clopidogrel P2Y12 receptor blockers, clopidogrel, prasugrel, ticagrelor. The most common cause of stent thrombosis is poor adherence and inability to take the recommended direct acting platelet therapy. Concern for patients with limited access to medical care, those who are uninsured. So he has no insurance, that's why this is stent thrombosis is happened. The patient is currently unemployed and uninsured. You have found in the stem that and after he has done the procedure like stenting has done, but after stenting you need to have dual antiplatelet therapy for up to 12 months to prevent stent endothelialization, because we know that drug-eluting stent has more propensity of having stent thrombosis. Okay, okay, you want me to read the whole explanation? Yes. Okay. ACS due to stent thrombosis most commonly presents as an ST segment elevation myocardial valve infarction, but can manifest as non-ST elevated MI or unstable angina. It is associated with high morbidity and mortality, and therefore patients should be screened for barriers to medication adherence and counsel regarding the importance of taking direct acting dual antiplatelet therapy consistently, both at the time of stent placement and during follow-up. And option C, atherosclerotic plaque rupture. Atherosclerotic plaque rupture with thrombotic occlusion is typical cause of ST elevated MI. However, localization of this patient's stent thrombosis elevation leads to corresponding with his recently stented left anterior descending artery V1 to V4 makes stent thrombosis much more likely. Pathologically, the occlusion is not due to plaque rupture but rather to stent thrombosis. If if this patient has developed ST segment elevation in the lateral 1 AVL V5 V6 or inferior 2-3 AVF leads, this would have suggested a new atherosclerotic plaque rupture. So this point is important. Okay, why it is not left ventricular aneurysm? Left ventricular aneurysm is a mechanical complication that can occur up to several months following transmural MI. It usually manifests with heart failure and can cause persistent ST elevation on ECG. persistent ST elevation on ECG. However, 10 days is relatively a short period and is unlikely to present with crushing substernal chest pain. Got it? Yes. Diffuse ST yes. Okay, ibuprofen with colchicine. So it is pericarditis according to ECG and according to the description. Okay. This patient most likely has acute viral pericarditis. Most cases of acute pericarditis Most cases of acute pericarditis are thought to be viral due to viral infection, and many viruses have implicated adenovirus, coccidiovirus, ecovirus, influenza virus, HIV. Patients typically have sharp chest pain that is worse with deep breathing, pleuritic, or swallowing, and many follow several days of a viral prodrome, fatigue, sore throat, myalgia. Auscultation of the left sternal border usually indicates pericardial friction rub. Auscultation of the left sternal border usually indicates pericardial friction rub, high frequency grating or scratching sound that is triphasic, occurring during atrial systole, ventricular systole, and early ventricular diastole. ECG characteristically show diffuse PR depression due to inflammation of the atrial myocardium and diffuse ST elevation due to inflammation of the ventricular myocardium. Diffuse PR depression due to inflammation of the atrial myocardium and diffuse ST elevation due to inflammation of the ventricular myocardium, but findings can vary. Pericardial effusion is present more than 50% of the cases. NSAIDs, ibuprofen, indomethacin in combination with colchicine are preferred treatment for patients with viral pericarditis. Colchicine decreases the rate of recurrent pericarditis in these patients. Next. Is it heart failure? Yes. So furosemide, like loop diuretics. Okay. Okay. This patient presentation dyspnea, orthopnea, paroxysmal nocturnal dyspnea, bibasilar crackles, hypoxemia is consistent with acute pulmonary edema, most likely due to acute decompensated heart failure from long-standing uncontrolled hypertension. Acute decompensated heart failure is usually due to left ventricular systolic or diastolic dysfunction with or without cardiac disease. Ventricular dysfunction. Initial management of acute decompensated heart failure. Acute decompensated heart failure involves the following: evaluate clinical stability. Evaluate clinical stability. Patients with evidence of respiratory failure should receive ventilatory support, non-invasive positive pressure, and patients with evidence of cardiogenic shock, severe hypotension should receive inotropic support, dobutamine. Improve symptoms. Prompt preload reduction can be achieved. Prompt preload reduction can be achieved with IV diuretics, furosemide, vasodilator. Nitroglycerin may be given to help to reduce preload. And balanced vasodilator nitroprusside may be given when afterload reduction is also needed. Afterload reduction is also needed. And investigate precipitating factor ECG and echocardiography help evaluate for precipitating factors including myocardial ischemia and arrhythmia, atrial fibrillation, and valvular severe MR. These clinically stable patients should receive supplemental oxygen, IV diuretics for preload reduction, and a balanced vasodilator, nitroprusside for preload and afterload reduction. Got it? Okay, we know that the DASH diet, light diet, high in fruits and vegetables and low in saturated fat has actually decreases the blood pressure a lot. Okay, do you want me to read the explanation of this? You know that. Okay, next. uh, you want to start tomorrow? We can. Okay. 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 Bye bye.